I chaired that report in 2001, and it had not been commissioned. I was asked to chair this, but nothing was commissioned with respect to the conclusions of the report. I know that, Mrs. Pimo, you'd like to be specific, and I'm clarifying that clarification. So it's a committee on drug insurance. And the mandate of the report was to establish the relevance and feasibility of a universal plan, that is, in quotes if you like, but universal, to the extent that everybody would be involved in a public plan for drug insurance. So the notion is that we have a mixed system. Do we want to simply have a completely public plan? Or the question had been raised whether or not we want a completely private plan, or should we keep this mixed system? And the conclusion of the report said that the mixed system seems to work. It enables everybody to have access to drugs without any major financial obstacles. Nobody claimed that it was perfect. If you were to reread the report from 2001, you'll see that it contained a number of recommendations to improve basic elements, but basically the system as we know it was reasonable. So why this? Do we prefer this mixed system compared to a completely private system? Well, let's be clear about this. A private plan is an agreement between an employer and employee. Nobody is forced to stay with the employer if he or she decides that this is not acceptable. It's an agreement. That is arbitration between a salary or coverage of drug insurance. Many are going to look for a job where the drug insurance is beneficial for all kinds of reasons. Perhaps they're more at risk. Or, on the contrary, those who are at risk are going to look for drug insurance that is private because they don't have to reveal the degree of risk they run, so that it is easy for them to access a number of different drugs and they'll be reimbursed for them. So it's an agreement between two parties. And when the agreement is no longer acceptable to the employee, all he has to do is to change jobs. So I realize that some employers are too small. They cannot offer a very comprehensive plan at a low price, so it becomes difficult, and you cited such an example earlier. But then you either have to change plan, you have to ensure that this group opens up to another plan or gets together with other plans. Currently, that's what we're seeing extensively in the market. Or you have to pay the appropriate incomes to make sure that these people can afford insurance, and that is not possible without consensus. And there are always challenges when people face constraints. They can face constraints, that's all. So we were against, and I'm still entirely against the idea of a completely private plan because there is an exclusion. If it is an entirely private plan, some people will not be eligible because, among other things, they don't have a job. So there has to be a public portion in the system. That seems to be very clear. So we could look at a universal drug insurance, basically. We could look at that notion. Just a point to revisit the notion of a completely private plan. If there are exclusions, if, let's say, you have free medical insurance downstream and you're going to be picking this up for the whole population, we don't want to see any exclusions. We want people to benefit from the fact that drugs help to treat people, it improves their well-being, and if we do not do this, then automatically they will be picked up by Medicare and will all pay. So that's not acceptable. As a result, basically, we want to see a universal system, in quotes rather, so that everybody can contribute to the plan, but that it is also a benefit for everybody to contribute to its funding. We also have to be careful about the silos that we often end up in these discussions. We look at the increased cost of drugs, but drugs are efficient. And at a certain point, it should reduce hospitalization rates. Both demands on both sides are rising. These are not separate issues, but it is a very dangerous silo to embark on, and I think we need to look at the system as a whole, both in terms of drugs as in terms of disease. So why not to retain the notion of a public drug insurance plan, as our colleague has put forth? And we'll hear about this during his election campaign, if I understood him correctly. So first of all, because the employer contributes. Sorry about that. So the employer's contribution to private plan frees up public resources, and that is the employer's contribution, not the employee's contribution, because his will be picked up in the public system through premiums, through taxes, etc. But the employer contributes to this private insurance plan for all citizens who can sign on to a private plan. And that's approximately $2.5 to $3 billion in Quebec. Again, I'm speaking about the Quebec context. It frees up $3 billion, $2.5 to $3 billion from the public sector. It makes it possible to earmark that money for elsewhere, education, just to go back a little bit to what's going on in the news. And I'm absolutely persuaded that employers would like to see this funding transferred to the public system, but the public system cannot perceive how it would be able to pick up all of the costs given the state of public finance, which already back in 2001, we're in a tough position with the recession we saw in the spring of 2002. So without saying that in 2012, the public financial situation is very difficult. So it would be very difficult to find between $2.5 and $3 million. So the fact that we have private plans, these are only insurance plans. There is no redistribution aspect, and contrary to Mrs. Fremont, I don't want to see insurance that has this redistribution part. It simply means that one shares risk, that one mitigates risk. If we want to redistribute resources, there are different ways of doing this. You transfer them. You don't use a system where there is risk mitigation simply to amuse oneself by redistributing risk, and I'll explain. But the fact that there's a private plan makes it also possible to extend coverage. There's always the notion of free services and these plans with the one who pays and the one who pays. So it's possible to see a problem with that. And there's a simple example. I have 5 minutes. Oh my goodness, it does pass fast. It seems to be longer for the other speakers. I'll try. So there's we have the INES here, which governs which drugs should be covered or not. There were cancer drugs, and pressure was put on the government. The government intervened for completely political reasons. They were certainly not medical reasons. That is absolutely true, and they simply canceled this. So that's the kind of drifting off we've seen. But if we have private plans, plus, people will pay. People can get what they want. But if we don't allow people to buy what they want, then we have a problem. So we'll simply buy Ladas rather than BMWs. At least some people will be driving those cars. So the private plans are more innovative. They provide more flexibility. They're more complicated in terms of the decision-making, and they're much more political. It is the market compared to political process, and we always lose in a political process. I'm not saying that the market is the best system. In fact, it is the very worst. It's hard to find a good one, and good luck if you try. So the obligatory, the compulsory feature of these plans is a major element, and we must ensure the contribution by all the insured. Now, the premium. So all covered people, insured people must contribute, so we're sharing risks. So perhaps I won't need it, but at the very least the plan will there, so I pay a premium to ensure that there's coverage. That's the notion of premium. Again, this depends between $0 and $525, so it's progression. It's based on revenue. Now, the deductible. Deductible is when you have a prescription that you need to have filled the first time, then you're going to pay for your drugs if it's over $16. I find that deductible somewhat useless. In our report, we had suggested dropping it. It's complicated. It does not necessarily reduce administrative costs. It's too little. Perhaps if it were for $40, it would not trigger the whole bureaucracy for a simple amount of $16. It's very hard to buy drugs under $16 at this point. And there is copayment, and that's a module for consumption. So we're very careful in Quebec. We want to make sure that people won't go bust. So, of course, if you're sick and you need drugs, you have to be able to pay for them, but nobody is going to get poor because there is a cap. At least they won't go bankrupt once because you have to buy certain drugs to get better. So we have these drugs, but for those of you who are not economists, that is, if we increase the price, is there going to be a response in the amount of in the quantity of drugs available? It's rather elastic, and there's not much change in the quantity when there's a rise in prices. But in actual fact, what happens when the prices go down? If you remove these premiums of co-payment, everything's going to go down. We've had very few cases where the prices drop substantially, and we saw what happened. So I think this notion of user payer is efficient because it enables me to see whether or not I want this drug, whether it's important. And there are people who take drugs because they need them. Others take them because they think they need them. We have all kinds of cases, and I could cite some specific examples. There are some as well. So one of the major reasons why we should have co-payment is to ensure that we're also concerned with prevention. The both should be linked. So we're looking at prevention. People will behave in a way that incites prevention. So if you don't have to pay anything at all in the system, that's fine. But if you do have to pay, then one will look at prevention. And I think prevention specifically through nutrition, physical activity is no doubt far more efficient than any type of healthcare system that we could put in place or any kind of drug insurance plan. Let's come back to the redistribution of income. We should never use prices to calculate the redistribution of income. That's a major mistake. Once you agree to freeze prices, whether it be education or health, you prevent the more fortunate to pay for the less fortunate. I call that a policy of the right, contrary to what some have claimed. If you allow prices to adjust, some people will have less access to drugs or the systems because the prices are not right. All you have to do is provide them with the necessary funds, but don't work on the prices. That has to do with reallocation of these resources, not redistribution. So is this a good system? Yes, of course. Is it a model? Yes. Is it a model for the rest of Canada? I have no idea. It's up to each province to say whether or not they're willing to pay several million into the system. It's up to them to decide, but I think it could be of interest to them. Nonetheless, I think this system could be extremely attractive for health insurance, and I'd like to apply it. We already have a premium. Mrs. Fremont will be speaking about taxes, but it is a premium. That is, it enables the system to manage the funds and the finesse. It allows the system to manage these costs. And we should have kept the user fee because without this user fee, we're going exactly where we don't want to go. Because if you have a premium, that is regardless of how you use the system of the healthcare system, you're going to pay. So you're going to try to amortize. You'll want to write off your premium. You're going to be using the healthcare system even more. And the user fee had to put a break into this. It had halted it somewhat. But everybody understands that. Physicians understand it. For those of us in Quebec, remember that all of the physicians were in favor of the premium, not in favor of the user fee. It's fee-for-service payment here. So that is why they agreed with this. So the result, politically speaking, economically speaking, this system is exportable. Politically, however, it will not be exportable because in the drug insurance, we had a system where people had to pay towards a system where people were basically paying less in the public sector. So you're going from a system where everything is free, and then suddenly you're asking people to pay. That won't work. And what will be the repercussions, like in health, like in education? We're simply going to see a drop in quality over time. Thank you.